Alright, starting the next system, neurology for MRCP part 1. So, for neurology, there's a lot of things that we need to address, a lot of topics, a lot of things we need to clarify before we really jump onto the questions. This will cover almost everything that needs to be revised. Okay, neurology basics. First is anatomy and physiology. What's there for frontal lobe? What's the functions of frontal lobe and abnormalities? Well, here they are talking about only abnormalities, difficulties with task sequencing, difficulties with executive skills, expressive aphasia. That's Broca's area, very common question. Located in the posterior aspect of the frontal lobe in inferior frontal gyrus. Anosmia, there is lack of smell. Then primitive reflex, perseveration, absent primitive reflex, perseveration, repeatedly asking the same question, doing the same thing, changes in personality, inability to generate a list, disinhibition. So these are some of the things which are happening when there's a lesion in frontal lobe or there's any problem in the frontal lobe. And the most important one is expressive aphasia happening in Broca's area. We'll talk in details about it later. About parietal lobe abnormalities would be apraxia, loss of the ability to execute, learn purposeful movement, and neglect, inattention, stereognosis, unable to recognize object by feeling, tactile agnosia, uh, homonymous inferior quadrantopia. So inferior quadrantopia, so which means basically the inferior side of the visual field. We'll be coming to that in the next part about this. Parietal lobe inferior quadrantopia, homonymous. Sensory inattention, acalculia, inability to perform mental arithmetic. Gerstmann syndrome, lesion of the dominant parietal lobe, will cause alexia, inability to read, acalculia, finger agnosia, right-left orientation. These things need to be like in the head totally for the exam. Temporal lobe Wernicke's aphasia. It's also called receptive aphasia. Homonymous superior quadrantopia, and this is a superior, and this for parietal is inferior. We'll come to that in the visual field section. Then temporal lobe also has auditory agnosia, prosopagnosia, difficulty recognizing faces, something to do with the memory. Occipital lobe is the one which occipital lobe lesion may cause cortical blindness. Blindness due to damage to visual cortex may present as Anton syndrome. There is blindness, but patient is unaware or denies blindness. Okay, this might happen. Homonymous hemianopia. Once again, we'll be coming towards it in the visual field section. Visual agnosia, seeing but not perceiving objects, is basically you see something, it's different, but you don't understand what is it. It's different to neglect sense. In agnosia, the objects are seen and followed but cannot be named. So this list is super duper important and have to be memorized and kept for future purpose as well. Okay, now some other things about the dorsal column dysfunction. You know about the dorsal column, it's like it's in the spinal cord, and the spinal cord is like this, and there's this anterior section, the posterior section. It's in the posterior section where the dorsal column is. It controls joint position and light touch. Remember this, joint position and light touch. Spinothalamic dysfunction, pinprick, and temperature. Spinothalamic would be in the anterior position. Thalamic and frontal lobe infarcts do not cause visual field defects. So these are like key points you need to remember. Okay, neurology and driving rules. Okay, for driving rules, first seizure 6 months of driving. So if there is any seizure, first time 6 months of driving. If the license holder has undergone assessment by an appropriate specialist and no relevant abnormality has been identified, for example, EEG and brain scan are indicated. For patients with established epilepsy, they must be fit free for 12 months before being able to drive. So established epilepsy 12 months, unless they are fit free, as in seizure free. Stroke or TIA 1 month of driving, multiple TIAs over a short period of time, 3 months of driving, and must inform LDVLA. Craniotomy for meningioma, 1 year of driving. With benign tumors, if there is no seizure history, license can be reconsidered. in 6 months. Pituitary tumor, craniotomy 6 months. Transperineal surgery can drive when there's no debarring residual impairment. Narcolepsy, catalepsy, C is driving on diagnosis. So this is where you can't drive. It's like no syncope, simple faint, no restriction. Unexplained, low risk of recurrence, 4 weeks off. Explained and treated, 4 weeks off. Unexplained, 6 months off. Okay, neuro-ophthalmology, very important to know and understand the visual field defect. So this is like the whole visual field, the visual tract. You can see here the optic nerve. These are both eyes, the optic nerve, then there's the optic chiasma in the middle, optic tract on both sides, radiation of the occipital cortex. So this thing is something you really need to understand, and you need to know which lesion which may cause what problem. Okay, so let's go through the theories as well. Okay, before that we'll just go through this thing. So you can see that nerve endings from this side is going and crossing towards that side, the medial side, as in the medial side nerve ending, which detects image from the lateral side. Okay, the left side, this is left, this is right. So left side, it will be falling over here and it's gonna be taken over to the other side, and this one, the lateral side ones will be taken from this right side and it will go towards the same side of the brain, and there's a crisscross here. So what happens is when there's an injury in the optic nerve 1, that is, you see, injury in the optic nerve is basically 2, here you see. So what happens if there is 2, like for example this is the right side optic nerve is damaged. So what happens is, in this eye, there will be blindness, monocular blindness, since the whole eye is off. So this whole eye, you see, it's black and this is white. So this is all right, this is gone. If it's in optic chiasma, there's 3. So what happens is, you can see over here 3. Where is it? 3 is bitemporal hemianopia, because you can see this is 3. What happens is both sides, both temporal regions are blocked. You know why? Because this and this, the lateral ones are blocked, because the lateral ones, for example, this one will be the middle ones are blocked, the lateral ones are spared in actually. If you can see, like the lateral one, you see it's active, right? It's coming and it's going towards the same side without being cut off. And this one, the lateral side, is active, going towards the same side without being cut off. But the medial ones, this and this, has been cut off here. So the medial ones are controlling the image from the lateral side. So that's why the lateral side image is off. So this is something you have to like go over and over again to understand better. This is for optic chiasma. If it's optic, if it's like number 4 is hemianopia. It's just one nerve going out. It's easy to understand. What if it's in the optic tract? If it's in the optic tract, what happens is, like you see, the whole optic tract is gone. So all this lateral side from this eye, medial side from this eye will be gone. So you see, and same thing over here, same thing in 8. Bit of differences might be there, but this is called homonymous hemianopia. Like, difference, both eyes same side, the lateral side, homonymous hemianopia. And there's incongruous and congruous, where we will be coming to that. So firstly, the thing you have to understand is this tract, how does it work, and then come towards this homonymous hemianopia. Incongruous defect is optic tract lesion. Incongruous defect, you can see here, this whole thing is, they are not symmetrical, it's incongruous defect. Okay, so this is for optic tract lesion, may cause this kind of homonymous hemianopia. This is like in 3 bitemporal, all the temporal sides are having block as in like no vision. And for optic tract, as you can see here, the lateral sides are missing. The lateral side of this eye and the middle side of this eye, homonymously hemianopia. Incongruous, since it's not symmetrical. And congruous will be when it's a lesion in the optic radiation here, homonymous hemianopia, but congruous, almost symmetrical. Okay, so for incongruous defect, it's optic tract lesion. Congruous defect is approximately the same in each eye. That's what I was trying to say. Optic radiation lesion or occipital cortex. In fact, occipital cortex and optic tract radiation is like similar type of problem is happening. Yeah. Macular sparing lesion of occipital cortex. So in occipital cortex there's one difference, that is macular sparing. The middle part is spared. You see, number 9 of the book, macular sparing. Okay, right homonymous hemianopia means what? Right homonymous hemianopia means visual field defect to the right, lesion of the right optic tract. So right optic tract, if you can think about it, optic tract, this is the right side, right? No, this is the as in this is the left side. Right, there is a slight mistake over here. Basically you can see that right homonymous hemianopia, this is right homonymous hemianopia, as in the right sides are blocked, right? So it means visual field defect to the right, obviously defect to the right, lesion of the left optic tract. So this is the left optic tract being cut off, which means right homonymous hemianopia. All right, so this next would be homonymous quadrantopia. Quadrantopia is like, a quadrant, like this one is a quadrant of the circle. So when a quadrant is missing, superior homonymous quadrantopia. Okay, superior homonymous quadrantopia is basically this. If you can think about 6, number 6, this is on the left side, temporal region. So temporal region, what happens is right superior homonymous quadrantopia, the upper side is gone. Homonymous as in it says in the same portion of both the eyes. Quadrantopia since it's quarter. And for inferior, lesion of the parietal lobe, that is 7, that is here. Right, inferior homonymous quadrantopia is like this side is gone. Since there's a mnemonic for this, it's called PITS, parietal inferior to temporal superior. So what you need to remember is basically I'm coming to that again. The next part would be bitemporal hemianopia. I've already talked about it. Lesion of the optic chiasm, very important. This comes very often. And then you see the visual is usually like this, like you don't see the temporal regions, you just only see the middle portion. So now there's also another thing which you need to understand, that upper quadrant defect more than lower quadrant defect. So it might be like this, that the upper quadrant that you see is like lesser than the lower quadrant. When upper quadrant defect is more than lower, it means an inferior chiasmal compression, commonly a pituitary tumor. So basically there is some force from downwards, like a pituitary tumor. And when lower quadrant defect is more than upper quadrant defect, it's like a superior pressure compression, commonly a craniopharyngioma. Very important and common question in MRCP part 1. Okay, for this to understand, you really need to go through it again and again and again. So just telling you some hints, like for 2. Okay, for optic tract, so optic nerve, for optic nerve it's on the same side, like as in this is the right eye, this is the left eye, right? So when there's damage to optic nerve of the right eye faces blindness. But if it's optic chiasm, is like both eyes have the bitemporal damage in the visual field. And if there is optic tract lesion, like this one, optic tract, so this optic tract, as in left optic tract, will cause damage to right vision, opposite. Okay, even if it's like here, from down here after optic chiasm, everything is opposite, like the damage will be done in the opposite eye, depending on not damage in the opposite eye, as in the sides will be different. For example, as I was saying, the optic tract. So optic tract, this is the left eye having the lesion, left circuit is having the lesion, but the damage is down on the right side, right homonymous hemianopia, right? So that's what I'm talking about. The fields will be different. And then it goes onwards in the same way. Hope you've understood the whole thing, and let's move on to the next part, that is nystagmus. Nystagmus is voluntary oscillations of the eye. This may be pendular when the oscillations are equal in rate and amplitude, or jerking when there are quick and slow phases. Okay, the quicker phase is used to define the direction. Okay, nystagmus, what can be the cause of nystagmus? Visual disturbance, lesions of the labyrinth, the central vestibular connection, brainstem or cerebellar lesion. Okay. Nystagmus types. Nystagmus which changes with the direction of the gaze, involvement of vestibular nuclei. Pendular, mostly due to loss of macular vision, could be in the diffuse brainstem lesion. jerking regardless of the direction of gaze, labyrinthine, or cerebellar lesion. So the types you have to remember, pendular, direction of gaze, jerking on lateral gaze and fast in the direction of gaze, brainstem or cerebellum lesion. Nystagmus, confined to one eye, is nerve or muscle lesion or medial longitudinal bundle lesion. Nystagmus restricted to the abducting eye on lateral gaze is due to a lesion of the medial longitudinal bundle between pons and midbrain, as in multiple sclerosis. We're going to come to that again later. Wernicke's thiamine deficiency is a rare cause of downbeat nystagmus. Okay, medial longitudinal bundle. It coordinates the lateral rectus of one side with the medial rectus of the other side. Very important in conjugate eye movements. And upbeat nystagmus, cerebellar vermis lesion, downbeat nystagmus, foramen magnum lesion, or Arnold-Chiari malformation. All these need to be recalled for the exams. Okay, now coming to the next portion is ptosis plus dilated pupil. So if you have ptosis and dilated pupil, this is basically third nerve palsy. This ptosis with constricted pupil is Horner's syndrome. Okay, what are the causes of meiosis? These are just like key points. Meiosis would be small pupil. Causes would be Horner's syndrome, Argyll-Robertson pupil, senile meiosis, pontine hemorrhage, congenital. And drug causes are opiates, pathomimetics like pilocarpine, organophosphate toxicity. So these are the main causes of meiosis of small pupil. Holmes-Eddy pupil is a benign condition characterized by tonically dilated pupil that reacts slowly to light but shows normal response to accommodation. So it reacts slowly to light but shows normal response to accommodation. It's frequently seen in females with absent knee or ankle jerks and impaired sweating. It's one of the differentials of a dilated pupil. So it reacts slowly to light. It's tonically dilated pupil, but there's like normal response to accommodation. You can look far and near normally. What is Argyll-Robertson pupil? It's also mentioned here. Okay. It's small irregular pupils that do not react to light but react to accommodation. Referred to as whore's eye because of the association with tertiary syphilis and because of the convenient mnemonic that like prostitutes accommodate but do not react well. Okay. Causes would be multiple sclerosis, sarcoidosis, DM. Okay, coming to Horner's syndrome. Okay, Horner's syndrome is a very important thing. What you see in Horner's syndrome basically meiosis, small pupil, ptosis, like this ptosis. In ophthalmos sunken eye, the appearance is due to a normal palpebral aperture rather than true ophthalmos. Narrow palpebral aperture, like this distance is like covering the eyes rather than true ophthalmos. Anhydrous, loss of sweating on one side. Okay, distinguishing between causes. Heterochromia, difference in iris color is seen in congenital Horner's, like in the opposite figure. Here you see different colors of eyes. Note the left eye color different. Anhydrous, see below. Horner's syndrome anhydrous determines site of lesion. Head, arm, and trunk will be central lesion, like stroke or syringomyelia. Just face, preganglionic lesion like Pancoast tumor or cervical rib. Absent would be postganglionic region like carotid artery. So it's all written here again. Horner's syndrome, central lesions, face, arm, and trunk anhydrosis, stroke, syringomyelia, multiple sclerosis, tumor, encephalitis, face anhydrosis, Pancoast tumor, cervical rib trauma, thyroidectomy, no anhydrosis, carotid artery dissection, carotid aneurysm, cavernous sinus thrombosis, cluster-headache. Okay, and ptosis. What are the causes of ptosis? Unilateral will be third nerve palsy, Horner's syndrome. Bilateral causes can also cause unilateral ptosis. Cause of bilateral myostonic dystrophy, myasthenia gravis, syphilis, congenital. Right, third nerve palsy. Third nerve palsy, one thing you have to remember is down and out. The eyes are down and out like this. See, down and out. Ptosis is there of this eye. Pupil may be dilated, sometimes called surgical third nerve palsy, and there's PC aneurysm. So pain plus third nerve palsy is posterior communicating artery aneurysm. In a combination of headache and third nerve palsy, it's important to exclude PC aneurysm. Causes might be diabetes mellitus, cause of part of cerebrovascular complications. Vasculitis may be there, temporal artery SLE. False localizing sign due to uncal herniation through tentorium with raised ICP. Posterior communicating artery aneurysm, pupil dilated. Cavernous sinus thrombosis, Weber syndrome. Ipsilateral third nerve palsy with contralateral. Okay, this is another thing which is important. Weber syndrome. Ipsilateral third nerve palsy with contralateral hemiplegia caused by midbrain strokes. Cerebral canonical. Other possible cause amyloid MS. So midbrain can cause this ipsilateral third nerve damage. We know that in midbrain there is third nerve nucleus. So contralateral hemiplegia may also be caused with that. Okay, moving on to general neurology. We talked about the basic. Till now we've talked about physiology and anatomy as well. Now we're going to go for the diseases and problems that are there. So many are there. Okay, general neurology. Acute confusion delirium. It's a very common thing we find in hospitals. Acute organic brain syndrome, it affects up to 30% of elderly patients admitted in hospital. Management largely depends on treating the cause like infection or urinary retention, constipation, pain, hypercalcemia, and medication. Okay, what are the features that are there? It can be memory disturbance like loss of short term more than long term, maybe very agitated or withdrawal, hypoactive delirium, disorientation, mood change, visual hallucination, disturbed sleep cycle, poor attention. Treatment of the underlying cause is important. Modification of environment, haloperidol 0.5 mg as first line is given for acute confusion state. Consider midazolam in management of dying patient. Haloperidol half milligram orally is better, not 5 mg orally. Okay, alcohol related brain damage, a very important thing as well. Wernicke's encephalopathy, acute syndrome caused by lesion in the medial thalamic nuclei, mammillary bodies, periaqueductal and periventricular brainstem nuclei, and superior cerebellar vermis. So all these regions near the thalamus, often resulting from inadequate intake or absorption of thiamine, especially in conjunction with carbohydrate ingestion. Malnourished person receiving dextrose infusion. Its most common correlated is prolonged alcohol consumption. That's the main thing here, resulting in thiamine deficiency. In Wernicke's encephalopathy, petechial hemorrhage occur in a variety of structures in the brain, including the mammillary bodies and the ventricle wall. Very important. The features can be for Wernicke's encephalopathy is like nystagmus, ophthalmoplegia, ataxia, confused altered GCS, peripheral sensory neuropathy, impairment of short-term memory. The causes might be lack of vitamin B1 ingestion, alcohol, chronic gastritis, distributive vomiting, bulimia, post bariatric surgery, cancer. Okay, there's this thing called Korsakoff syndrome. What is it? Basically a chronic memory disorder caused by severe deficiency of thiamine. So Wernicke is basically starting, Korsakoff is the ending. When Wernicke's encephalopathy is untreated or not treated soon enough, Korsakoff syndrome usually develops. It is the most well-known form of alcohol-related brain damage. Inability to acquire new memories and confabulation, making up stuff, suggests the development of Korsakoff syndrome. So what is confabulation again? Confabulation is basically a symptom of various memory disorders in which made-up stories fill any gaps in memories. Example of confabulation is the patient who gives different history to different doctors. Due to memory issues, they fill the gaps in their memory by making up stories that normally makes sense to the listener. Okay. Next thing is Marcia-Fava Bignami disease, a progressive neurological disease of the alcoholism characterized by corpus callosum demyelination and necrosis and subsequent atrophy. Presentation is type A and type B, stupor and coma predominant, and symptoms of the upper motor neurons, involved with the entire corpus callosum, 21% mortality. Type B is like normal or only impaired mental status, 0% mortality. Investigation MRI or decreased red cell transcatalysis. Management would be thiamine for at least 5 days, then oral replacement. And for this, for acute alcohol withdrawal, managed using clinical institute withdrawal assessment, alcohol revised scale, where diazem is more important to prevent seizures. A very important and common topic: normal pressure hydrocephalus. Okay, normal pressure hydrocephalus is a reversible cause of dementia seen in elderly patients. It's thought to be secondary to decreased CSF absorption at the agnoid villi. These changes may be secondary to head injury, subarachnoid hemorrhage, or meningitis. So for this NPH, there is like a triad. It's like urinary incontinence, gait abnormality, dementia. Urinary incontinence, gait abnormality, and dementia. This is like the triad of NPH. Happens in elderly people. This is mentioned again. Classical triad of urinary incontinence, dementia, and bradyphrenia, slowness of thought. Gait abnormality may be similar to Parkinson's, and you can see a CT scan of normal head, and there's NPH, very dilated ventricles, lateral ventricles. Hydrocephalus with an enlarged fourth ventricle. Okay. And then ventriculoperitoneal shunting is there as management. Next to it is idiopathic intracranial hypertension, also known as pseudotumor cerebri, and formerly benign intracranial hypertension. This one was normal pressure hydrocephalus. This is intracranial hypertension, IIH. It's condition classically seen in young overweight females. So obese young female with headache and blurred vision. Headache and blurred vision. Obese young female with headache and blurred vision. Think about idiopathic intracranial hypertension. So what are the features that are there? Headache, blurred vision, papilloedema, enlarged blind spot, 6-nerve pulse may be present. Risk factors will be obesity, female, pregnancy, drugs in this case, like oral OCP, steroids, tetracycline, or vitamin A. What you can do is do CT scan, lumbar puncture, cerebral MRI with MR venography. Management would be number 1, weight loss. Number 2, diuretics like acetazolamide. Corticosteroids can be given. Repeated lumbar puncture. And surgery like optic nerve sheath decompression and fenestration may be needed to prevent damage to the optic nerve. That will be helpful for the vision part. Lumbar peritoneal shunt or ventricular peritoneal shunt may also be performed to decrease the intracranial pressure. So this is like too much ICP. Intracranial pressure is high, very high, because of no known reason. So these are the management that you can go for. Okay, something also very important: narcolepsy, cataplexy, all these. Narcolepsy is a condition causing excessive daytime sleepiness or somnolence and an overwhelming desire to sleep the whole day. Symptoms include excessive daytime sleepiness, involuntary sleep episodes, microsleeps, cataplexy. That's coming again later. Sleep paralysis, hallucination, hypnagogic at the onset of sleep, and hypnopompic on awakening. So sleep paralysis, hallucinations while you're going to sleep, while you're about to wake up. There is a disruption in the usual pattern of non-rapid eye movement sleep and rapid eye movement sleep. As a consequence, this causes difficulty in staying asleep and in staying awake, and bouts of irresistible daytime sleepiness under unusual circumstances while eating or talking. So, out of nowhere, you just sleep. Cataplexy describes the loss of muscular tone caused by a strong emotion, laughter, being frightened, and 2/3 of patients with narcolepsy have cataplexy. Loss of muscular tone caused by strong emotions. Okay. Diagnosis of narcolepsy requires assessment in a specialist center with facilities for multiple sleep latency tests and polysomnography. Treatment is based on lifestyle modification and the use of wakefulness promoting medications such as modafinil and sodium oxybutyrate. Wakefulness. Okay, must not drive and must notify the DVLA. A license may be reissued only when there has been satisfactory symptom control for at least 3 months before being considered for relicensing. So it's very important. Next is a huge topic, epilepsy, who covers a lot of things in neurology. We'll be doing it in the next class.